morning. There is no commercial support for today's activity. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. I would like to introduce Dr. Foxhall, who is with our physicians group of surgery department.
Thank you. A little housekeeping to begin with. We do have a breakfast reception right over here after we complete our lecture. And I was also going to thank Dr. Elaine Lilly for her hard work in improving our grand rounds. I don't see that she's here today, but she's put a lot of hard work and dedication into improving not only the quality of our didactics, but also the quality of the presenters.
I'd wait till after the talk to figure that out.
But so I think that's all my housekeeping. It's my pleasure to introduce Dr. Charles Staley, who is the Holland Ware Professor of Surgery and Chief of the Division of Surgical Oncology at the Emory University School of Medicine. He began his career at Dartmouth Medical School, where he was an honor graduate. He then went to the University of Pittsburgh, where he did his general surgery residency before going on to MD Anderson to do his surgical oncology fellowship. After his fellowship, he returned to Emory, starting his career of surgical education, research, and mentoring. He has mentored many surgeons, not only at Emory, but also at our institution, statewide, nationwide, and he's had a positive influence on them all. Let's see, he continues to have leadership positions, not only at Winship Cancer Center, but statewide and nationwide. His bibliography is amazing, 207 peer-reviewed publications and over 16 books or chapters. We first met 10 years ago at the Georgia Surgical Society, where Dr. Pepper Brown was president. Dr. Charles Staley was president-elect. Since then, Dr. Staley and I have met up about once a year, only held up by the occasional hurricane and COVID pandemic. This last October, he gave the Whitaker Lecture, which is our keynote address for our society, given by one of the members. And I can't remember the exact title, but it was there is hope after cancer and survival. It was very inspirational, and I'm looking forward to his talk today on the surgical treatment of peritoneal cancers. This is a subject that he's dedicated a lot of hard work, time, and research in, and is certainly one of the world's leading authorities on that. It is my privilege and honor to welcome Dr. Staley to the podium.
Thank you, Ed. Thank you, Dr. Foxhall, for that very nice and generous introduction. What I'm going to be talking about today is an example of if you just want to do something, do it. I had kind of a midlife crisis when I turned 50, and in that inspiration, I felt that I needed a bigger challenge. I may have bit off a little bit more than I could handle, but this disease and this disease entity has evolved so much, as I'll point out. I literally had to start from scratch. I didn't know anything about peritoneal malignancies in 2009 when I was 50 years old. And if you dig into it and call a bunch of friends, you actually can become a world's expert in a matter of years, because there weren't any experts. And as I'll see, there's one slide here which will pay off dividends for you on the ABSCITE exam and on your boards, because they ask a question every single year about appendiceal malignancies. So I have no disclosures financially. I do claim this fella as a relative of mine that you all probably know. Not that he looks anything like his dad. But when I was in your shoes back in the 80s, and we opened a belly and saw this amount of disease on an omentum, we sort of not emotionally and jokingly called this the peek and shriek. We thought there was no chance a surgical endeavor was going to help this patient stuff the omentum back in and send them off to the medical oncologist for chemotherapy for life. And what I'll hopefully show you is that this has become a surgical specialty. The one thing that I always start any talk on is something that Blake Cady, who was a very famous surgical oncologist in Boston, said, and this is something for you all to remember throughout your career, is that tumor biology is the king, patient selection's the queen, and the surgical procedure's the prince. Now, if the prince gets all high and mighty and thinks that he can overcome either one of those two, it's gonna bite you and make you a very humble individual. Remember that. So the technical exercise is actually the easiest part of deciding about cancer patients. And that's why during my fellowship, the most I learned was when to operate on somebody and who to operate on, not how to do a mastectomy or not how to do a colectomy. So the diseases we're going to talk about this morning are diseases that have a high propensity to spread into the peritoneum. So obviously, mesothelioma is a primary peritoneal cancer. The rest of these are metastatic cancers that are prone to spread to the peritoneum. Now, the subject of cytoreduction in HIPEC, which is a procedure, a long procedure of 6 to 12 hours, which is why I don't understand why I started doing that at the age of 50, is a 3-stage process where you go in, remove all the cancer, slosh around a hot chemotherapy for 90 minutes, and then put all the pieces back together again. As you can see, it's been around for 30, 40 years, but the real increase in publications occurred in the last 15, 20 years. The reason I got into this was, even though Dr. Sugarbaker's been doing this procedure called the shake and bake way back 30, 40 years ago, there's never been a clinical trial in the United States that proves its efficacy. It's sort of just become the wave by popularity. Now, what I have to convince you is that the peritoneum is actually a resectable organ. You can literally get in the right plane and strip the peritoneum in one layer. And that's what you got to do. Otherwise, you'd be picking hundreds and thousands of little tumors. So we consider it a resectable organ. And the goal of the cytoreduction is to remove all the peritoneal tumor and all the abdominal tumor. Now, the hyperthermic intraperitoneal chemotherapy is the caveat we don't know much about its true benefit. Its scientific value is that it can directly invade up to 4 millimeters into tumors. You can use a gigantic concentration of chemo because very little gets into the systemic circulation. And there's synergism between hyperthermia and the chemotherapy, at least for mitomycin, which is an old colon cancer drug. Nothing we would use systemically in this world, but for some reason in this disease, it seems to work. Now, there are two things that are universal when we talk about HIPEC for anybody. The two survival factors are independently their ECOG performance status and whether or not you can remove all the tumor. So that has got to be the goal of the surgery. I tell everybody in pre-op, if I can remove all of it, we're not going to do it. We're not going to do 5/8. We're not going to do 6/8. It's got to be all or nothing. So that's what you're looking for in a patient. Resectable disease, they're in good shape. You got to have a colonoscopy because you can feel on the outside, but you can't feel on the inside. If somebody's got a 4-centimeter villus adenoma, you're going to be embarrassed to leave that behind. So you got to make sure the colon's clear. Good contrasted CTs. PET scans are, in my mind, the biggest nemesis in this disease. Most mucinous tumors, which tend to spread to the peritoneum, are worthless in PET scans. And so with a lot of medical oncologists swear by them, but in certain diseases like this, they are not helpful. And then tumor markers. CEA seems to be good in colon. CA-125 is more sensitive in ovarian and appendiceal. This is sort of the procedure of what we do. Everybody's in lithotomy. We use epidurals for pain. Everybody gets ureteral stents, so we know where the ureters are and we don't end up cutting one. And we move along through a gigantic, they call it the Staley incision. Everybody else is making smaller incisions. I make bigger ones. So basically from the xiphoid to the pubis, because you've got to see every surface. So as I said, you've got to be able to strip the peritoneum. The first thing we do when we go in is you got to assess the small bowel. Whether you're going to do this or not depends on the small bowel, because I've got to leave at least half of the small bowel for them to digest their food. I can remove the whole colon, the spleen, the distal panc. I can take out lots of stuff. But if there's serosal implants from the ligament of trites to the terminal ileum, can't do it. So don't spend a lot of time screwing around trying to figure out whether or not you can do it. So this is an example of how clean you can get it. This is a pelvis. This is the foot. This is the head. And as you can see, we've basically stripped the left lower quadrant pelvic and right lower quadrant peritoneums basically down to the retroperitoneal anatomy. We then hook up this bypass machine and we use a closed circuit to perfuse the hot chemo. And this is what it looks like. We whip stitch the skin closed and basically shake for 90 minutes. The residents sometimes watch Netflix. It gets a little crazy. Now, how do we assess the amount of disease? So the staging. Chris was asking me about some question he saw about how to assess the amount of, this is how we do it. Basically, every quadrant and the small intestine gets a score. It depends on the size And so you can have a score from 0 to 39. And that basically is a way that we quantitate the amount of disease. And then we quantitate it by the quality of the cytoreduction. Complete, minimal disease, and then leaving a bunch of disease. And these are not people we normally would cytoreduce. So this is an old slide. It's kind of interesting. We've gotten better at this. At the beginning, we had mortality rates of 4 to 5%. It's a lot. Now we're down to 1 to 2%, basically that of any large GI operation. But at the beginning, there was a lot of postoperative hemorrhage, bowel perforation. Basically now, we're down to kind of these 3 or 4 respiratory issues, abscesses, most of them CT-guided drained, anastomotic leaks of 8%, which is about what it is for a regular colectomy. And then the dreaded fistulas. And they're miserable. They'll haunt you for a long time. Now, the rarest and disease that most of you will never see is peritoneal mesothelioma. It's not necessarily linked to asbestos like pleural mesothelioma. Basically, people present with ascites and there's no other cause. You rule out gastric, colon, and someone sticks a laparoscope in, gets some tissue, and it comes up with a diagnosis. There's 3 types: epithelioid, sarcomatous, and when they can't figure it out. This is not a surgical disease. It's a medical oncology disease. Their survival is measured in less than a year. And we really haven't had great systemic therapies, but there is some new data on immunotherapy for pleural mesothelioma. And so for sarcomatoid, a lot of people are using immunotherapy. But with best medical care, survival is less than a year. Now, this is a case of mesothelioma. It's a very fleshy looking tumor. It's very unimpressive. You could miss it. It's not whitish like colon and other things. And this is the right upper quadrant where we're literally stripping the peritoneum off of the right diaphragm. So the key things to remember is that the majority of stuff we operate is epithelioid. It's actually the slowest growing. Most people present with a lot of disease, and thereby, whether you can totally reduce them is a 50-50 flip of the coin. But if you really look at a true benefit, this is a disease that this operation is actually beneficial. With no great help, systemic therapy, everybody's dead in a year and a half. Whereas if they go through cytoreduction, it's about a 50-50 long-term survival. The problem is that what drug to use for the cytoreduction part is not uniformly agreed upon, which we got to do better at. But if you have epithelioid and can remove everything, you have an 87-month median survival. I mean, I have people I follow that are doing incredibly well with this thought to be dismal disease. The interesting thing is that it's a field defect. If you look at a piece of peritoneum that doesn't have tumor on it and send it for frozen, there's mesothelioma there. So you wouldn't be surprised to know that unless you take all the peritoneum out, there's some people who are going to fail by leaving peritoneum behind. It's difficult to do a total peritonectomy. It's very time consuming. Now, appendiceal cancer, it actually is increasing. You can see from the 70s up, it's increasing. And I think, Pepper, you've called me with a bunch of them. you guys will see this. It's usually always found later. You did your appendectomy, they're in the office, you asked your nurse for the path report and bow, it's something. It's lamin, it's goblet cell. It's like, what in the world is this? And this is a slide, if anything, the one slide I want you guys to remember. Because there's multitudes of pathology for a stupid appendix. But by disease, if you have a neuroendocrine, we're getting away from carcinoid now. The terminology is more just neuroendocrine tumor. It's the 2 rule. If it's greater than 2, tends to be more metastatic, you need to do a right colectomy. If it's less than 2 centimeters, you cure them with your appendectomy. This is a confusing term because now it's called X-goblet cell, but it's a collision tumor. It has neuroendocrine and adenocarcinoma in it. Those people have a high, what drives all this is what is the likelihood of positive nodes? And in X-goblet cells, 75% will have positive nodes. So they go to colectomy. Moderately to poorly differentiated adenocarcinoma, colectomy. Interestingly, well-differentiated mucinous adenocarcinoma, the incidence of positive nodes is about 2%. So you can get away with just an appendectomy. And then this ambiguous term called lamin, which is low-grade mucinous neoplasm, isn't really a neoplasm. It has no ability to spread outside of the appendix, nodes or chest or liver. And all they need is an appendectomy. Now, you guys might do your lap appy and find a lamin with mucin in the right lower quadrant. The mucin that lamin makes is a byproduct. It's not tumor cells. So if you suck out the mucin and you got the lamin resected, then all they need is surveillance. If they have diffuse disease on the peritoneum or wherever, then they need a cytoreduction and HIPEC. So that's everything you needed to know about appendix. And this is what a mucinous lamin looks like. This is a hole where mucin just spews out of like a fountain. Now this is a condition, a clinical condition called Pseudomyxoma peritonei. It's not unique to appendix, but it's very prevalent. It can happen in an ovarian. We call these jelly bellies. They're full of jelly. They'll come in, they look like they have twins. And this is all mucin, like this. I think the last guy used, Mr. Martinez, was like that. And this is what it looks like. And when you look at this, you'd say, how in God's name could you get all that stuff out? But this stuff really doesn't stick to anything. You just literally have to power wash it off, basically. But this is the point of lamin, is that they're slow growing. They do very well. Virtually everybody will live 5 years. Some will have recurrence. But these are long-term survivals, and many of them are cured. And again, it depends on the volume of disease. The more disease you have, the worse the survival. Now we'll move into colon, which has become a little bit more controversial. You see how? So colon has been a little bit of a battle between medical oncologists and surgeons. The bottom line is you need both. You need chemo and you need a good surgeon. If you look at the biology of Mets, peritoneal Mets in this purple line seem to do worse than others, even with systemic chemotherapy. Now, how did we prove that this approach for colon might be reasonable. How do you convince medical oncologists? Well, if they agree that taking out a portion of the liver is beneficial, which most will do, you put the survival curves of hepatectomy patients on top of people who are having cytoreduction for colon cancer, and you see they're completely overlap. So if you believe in hepatectomy, you should believe in cytoreduction. Again, we're dealing with a whole bunch of small institutional trials without any real data to show it was beneficial. There was one study done in Europe back in the 80s where they took standard chemotherapy versus cytoreduction and HIPEC. Of course, everyone throws darts at this because they say 5-FU and leucovorin are not modern chemotherapy. But it was at that time, and it was in both arms. And the HIPEC group did twice as well as the systemic chemotherapy arm. So the key to this is both intraperitoneal and systemic therapy are important in colon cancer mets. Now, to point out what matters, somebody came up with this scoring. Everyone wants a nomogram or scoring system to help you decide what to operate on. If you just look at this, like clinical symptoms, the extent of carcinomatosis, the pathology, and you come up with stages. If you look at the major determinant, it's what? Tumor biology, histology. So if you have poorly differentiated cancer, you're 1 point from the worst stage, just based on that one factor. So if you put all this together, it would be reasonable if you had stage 1 and 2, you're going to do pretty well. If you have 3 and 4, you're probably only doing as well as if they had gotten systemic chemotherapy. And that is why in signet ring poorly differentiated tumors, we rarely will do cytoreduction and HIPEC. Now, the interesting thing is there seems to be a difference between colon and appendix signet ring. The appendix does a little bit better. But what this drives home is we have to do better than just histology. What we're finding now is people with BRAF mutations do poorly. And we're probably going to get to a point where molecular things, drive what we do. Now, the French started to look at other drugs. They said, Folfox is doing really well. Let's use oxaliplatin to do the wash. And they said, wow. They did a small phase 2 trial, and they said, look how much better this is. And the point of this for you guys, as you read papers in your career, the ultimate guide to deciding whether a therapy works or not are large phase 3 trials. Phase 1 and 2 are working things out. You should never take the result of a phase 1 or phase 2 to carry something to your practice. This was this mistake of the French. They thought this was better. They did this groundbreaking trial that has been a talk of meeting after meeting after meeting for years. They did a colon peritoneal disease, and they did cytoreduction with or without HIPEC. What does HIPEC add? Most of these people had low volume disease, median PCI of 10. They were able to completely cytoreduce them in most ways, 90% both sides. And of course, this is how you interpret data in the eye of the beholder. All the medical oncologists left the ASCO meeting saying what? Oh, see, HIPEC doesn't add anything. Y'all are nuts. Just do surgery. They all missed the fact that, look at the survival. With either one, almost a 4-year median survival. And with chemotherapy, it's about 2 years. We don't need to talk about that. So, the addition of oxaliplatin HIPEC doesn't work. Well, guess what? We would have never thought it would have. Because what did they do? They used 30 minutes of hyperthermia and a dose of oxaliplatin, and the pharmacokinetics of which would have never worked. But they took results of a phase 2 and said, we're just going to run with it. So this has hurt us more than helped us. But the key thing is there were excellent results with surgery and surgery with HIPEC. The question of the use of HIPEC is still up there. I've spent 8 to 10 years trying to get a study done, and one person in the NCI has blocked it. Very frustrating. Now, gastric cancer. You know, diagnostic laparoscopy is in the workup of everybody with gastric cancer. The amount of occult disease can be about 15%. And that obviously changes your plan as far as resection versus not. There's only one randomized trial from China, which rightly or wrongly everyone is very skeptical of. But this one randomized trial showed that cytoreduction in the HIPEC does better than surgery alone. So there's maybe a signal there. I've been working with a friend of mine out in California. There's a lot of enthusiasm. Again, this disease is more common in the Far East. You know, it's going down in America. But Taxol as a drug, in the Phoenix trial, this was a systemic chemo versus a intraperitoneal Taxol, and the intraperitoneal Taxol did better than systemic. And so we are about to start this trial at Emory and nationwide, where you get a diagnostic laparoscopy. If you have peritoneal disease, you get randomized to either systemic chemo or iterative, meaning repetitive. You'll probably remember the old ports, abdominal ports for GYN chemotherapy maybe. But we're going to be putting ports in the belly and giving them iterative Taxol to see if we can convert and shrink their peritoneal disease such that it'd be reasonable to do a HIPEC on them. So we'll see what this gives us. Now the last one I was going to talk about is a little out of the general surgery realm, but it has some real principles. Ovarian cancer, again, frequently metastasizes to the peritoneum. The standard had been surgical debulking and carbo. That's all they use in GYN world. Carbo, carbo, carbo. The Greeks did a small trial in this disease where they did cytoreduction, HIPEC, systemic chemo versus just surgery. And again, great results. So with the HIPEC, doubling survival, and it seemed to be not dependent on whether they were platinum sensitive or not. This is the trial that sort of got them on the map. Lead article in the New England Journal of Medicine by Dr. Van Drill in the Netherlands. 250 patients, stage 3 disease. They get neoadjuvant chemo and then surgery versus surgery and HIPEC. And clear winners, HIPEC, better than surgery alone. Now, in your own skeptical mind, you have to say, what the hell does 90 minutes of one dose of chemotherapy do in the abdominal cavity? And that's still a great question. But there are more and more trials like this that show a benefit. Now, quality of life is important. You know, when you pre-op a patient, you can tell them all the bad things that happen. But normally surgeons underestimate the recovery of these patients. These people are puny for months. So if you're going to offer them an operation like this, you better have a benefit of at least a year or more. Because if you're going to extend their life 4 months and they're going to spend 3 months getting over it, probably haven't helped them a whole lot. So quality of life is really important. So these are my lessons I've learned. We can do this operation safely. We really can. The benefit depends on tumor biology, so you got to pick the patients right. There's clearly a benefit of mesothelioma. The non-epithelioids are going to probably benefit from immunotherapy. The appendix stuff we went over, but lamin is a weird pathology. It's not a malignant tumor, but it's not benign. But by getting the treatment right based on if it's localized or diffuse, you can cure a whole bunch of people. Colon cancer, this is still of some debate, and there's going to be more research on it, but we think it's going to work out for us. The poorly differentiated signet rings, the way I look at this, these people you have to look at them individually. If somebody has been great on chemotherapy for a long period of time, then maybe somehow their biology is a little different. But the majority of these people fail very quickly. Gastric cancer, I think we're going to get somewhere there, and there's growing evidence of ovarian cancer. And I think the last thing I'll sort of tell you is we are behind medical oncology as far as personalized care. You go to somebody with stage 4 cancer, they're going to send it off to CRS, Foundation 1. You're going to get a report on 140 genes, some of which will be targeted therapy. What we're finding is that certain tumors are obviously respond to different chemos. So if you just say, we're going to give every colon cancer mitomycin, sometimes it probably works, sometimes it doesn't. And what can we do? Well, there's a sort of a platform called organoid development, where you basically grow the tumor in an environment similar to the body and then test it against chemotherapy. And what you can see is something like this, where the blue is the control, mito's yellow, oxalo are low dose, high dose. And you can see that in this control, huge kill of mitomycin, but oxali didn't work very well. So where I can see us going someday is diagnostic laparoscopy. Grow it up in an organoid. Give them neoadjuvant chemo. Figure out what drug you need to give them with the HIPEC, and that would be personalized HIPEC treatment. That's it. Not bad. So I hope I taught you something about this crazy disease. It's work intensive, and it brings you to your knees. I spend a lot of time going out and getting crackers and things like that, and I'm lucky to have talented residents like you that I can say, just clean up that small bowel, get all those nodules off there, I'll be back in an hour. And so this operation you've got to have residents to help you because it's a long haul when you get older. So I'm happy to answer any questions or anything.
When you're talking about the site of reduction, you're saying like you want less than 2.5 millimeters. You're talking about each nodule being less than 2.5 millimeters?
Anything in the belly.
Millimeters total in the whole belly.
No, each nodule. Okay. Because what we assume biologically is that the chemotherapy can penetrate 4 millimeters. So if you leave 50 nodules that are 1.5 centimeters, the chemo, if it's sensitive, should kill those. So you can't have a nodule greater than, say, 2.5 millimeters.
Can you talk a little bit about the physiology of the complications?
So the complications, as I tell people, what this really is 7, 8, 9 operations in one. So basically every operation has a complication. Each piece of bowel you take out can fall apart. Get too close to the stomach with the ligature, get a hole in it. The amount of bleeding complications, I believe, solely has gone down based on ligature technology. I mean, I've had 2 people that I've taken back for bleeding in 13 years. It's really remarkable. When you think of we're stripping the peritoneum, every capillary can bleed and everything else can bleed. But the biggest complications are abscesses and anastomotic leaks. And you just have to be, you got to be all over these patients every day. I tell the families, you may be looking great today and you may be in the ICU tomorrow. And so you just got to be all over them. One thing that we rarely see is SSI. Rarely have wound infections. And why? Mitomycin. It's an antibiotic. So we are doing a 90-minute washout of the subcutaneous tissue. So it's very rare to see an actual superficial wound infection.
Comment first, and that is, you did a great job of getting the hay down where the goats can eat it. I appreciate that. But one of the advantages of being a senior doctor is looking back and knowing how we got where we are.
Yeah.
What was the original inspiration for this? Was it based on pleurectomy for mesothelioma or something of that variety?
As you might imagine, and you have to go way, way back, but Paul Sugarbaker and his brother, who dedicated his life to pleural mesothelioma, were bantering around. And that's how they kind of developed this whole technology based on pleural mesothelioma and abdominal mesothelioma. And the thought that if somebody has a peritoneal nodule that went from here to here, like an ant stream, there's got to be something between the two, and you got to figure a way to treat microscopic disease.
And then, where does parenchymal disease fall with this? And most notably, I'm thinking of gastric cancer, where you have a diffuse gastric cancer, you get complete site reduction to the naked eye, but you've got positive margins, say on the omentum or something like, or even a parenchymal, a positive margin at the anastomosis.
Yeah, and when we do this, we always do the resection of the whatever first, and you have to take the frozen sections for what they're worth, because we've all seen negative frozen sections, and then at the permanent they go, oh, there was a cell there. But you just have to do your best to figure that out. The other thing that we debate about is, what do you do in colon if they have liver mets? Now, we have resected some folks with 1 or 2 liver mets, and they probably do just as well. But if somebody has multitudes of liver mets and peritoneal disease, probably not biologically going to help them. Interestingly, not all positive margins recur, which throws another wrench into it all. It's hard to know what that all means. You know, these things, they get into every surface. I mean, if you don't, you know, the two hardest places to cytoreduce are the porta hepatis and the pelvis. And I'll be honest with you, I have my liver surgeon, Mathel, come in because he loves to dig out the porta. I have no patience for that. I hate to say it. But I come back in and he's got vessel loops around every vessel and it all cleaned out to the nth degree. But if you don't get that cleared out, that's gonna be a source of a lot of problems. So we spend a lot of time on that. The pelvis, I've learned with time to do very well. And the Staley rule is, if you're gonna get into the bladder, get into it on top at the dome. Yes.
So you're taking out the peritoneal,
Peritoneum, yep.
peritoneum, parietal peritoneum,
Yeah.
and you're trying to leave 2.5 millimeters or less on the visceral peritoneum.
Yeah.
Some places.
If you have to.
You have to be able to take out half the small bowel. That means that the visceral peritoneum would have so much disease that you didn't think you could cytoreduce it to less than 2.5 millimeters.
Yeah, so what you do, especially like the appendix, the majority of the disease tends to be in the latter half of the terminal ileum. The proximal small bowel has very little disease. So we start at the ligament of Treitz and keep going, and we'll cytoreduce both sides of the mesentery, and then we get down to a point and we put a stitch there and say, to reduce the rest of this, we'll be here till Tuesday. We need to just resect it. And that's, you know, as I say to the residents, the key of this is get the big stuff out of the way and then start working your way down. Because you know physiologically you gotta keep certain things, but you wanna get all the disease out that you can get down to that 2.5 millimeters. Imaging is worthless in this disease other than to rule out distant mets. Everybody I open has more disease than you think. And so if they haven't had 4 incisions, we'll stick a laparoscope in. So it's based on if somebody's had 3 operations and we think getting in is gonna be more dangerous, we'll make a little mini laparotomy first and look at the small bowel. If not, we throw a scope in.
What are the how hot is the stuff you put in, and what's the complications of just the heat of it?
Yeah, good question. So we run the pump at 43 degrees centigrade.
What's that real number?
It's about 107, 108 degrees. And yeah, and we're circulating at 2 liters a minute. What we do is it's actually a great team. Everyone knows when to do things. About a half hour before we're gonna start, we shut all the anesthesia warmers off and we start the cooling blanket, start cooling down to 34 degrees. So we are notoriously starting the perfusion with an esophageal temp of 35 degrees centigrade. And then we will heat. And we'll get up to 38.5 or so. If we get up to 39, we have to pack ice bags around the upper body. And that usually will take care of it. But it's something we have to keep an eye on during the perfusion. Scientifically, what they've looked at in the lab is the length of hyperthermia and the exposure to the chemo. And that's why the 30 minutes probably wasn't enough. You need at least 60 minutes at 43 degrees to kill most tumors. So that's how the timing has sort of worked out.
And And following that logic, at what point is is there a point where it's more the heat than the chemo?
Great question.
I'm drawn to thinking about my sous vide that I
Oh,
get upstate.
right. It's a great question. And that's what happens when you define a therapy before you do all the hard work. And so the question is a good one. Is it the chemo, the temperature, or both? Not known. And to get back to your question, the major complication of the chemo is a prolonged ileus. These folks sit in the hospital for days just sitting there because their bowels just aren't working yet. And you feed them too early and they'll throw up in your face. Yeah, we sort of hedge our bets till about day 6. So if it looks like they're going to start eating by a week, we'll hold off. If it looks like they're not making them, we'll start them on TPN. And there are some people, maybe 5%, that go home on TPN. And obviously trying to feed them through a J tube or something is the same problem. So IV nutrition's about the only way to help that. Glad to be here.
We have